This is A&P Live Studio. I am your host. I teach A&P as a registered nurse and anatomy and physiology instructor for advanced level of healthcare pros. Today, we're going to explore the pathophysiology of hemophilia. We'll start with a real-world clinical story and follow the clues all the way down to the molecular level. It's a fascinating journey that shows us how a deficiency in just one tiny protein can cascade into a major systemic disorder. And then we'll look at the incredible ways modern medicine is designed to fix this very specific problem.
So here's our plan for today. We're going to start with a patient's story, just to ground all this science in the human experience. Then, we'll walk through the normal clotting process to see how it's supposed to work. After that, we'll pinpoint the exact defect in hemophilia, see how that leads to the clinical signs, and finally, look at how we diagnose and treat it right down to the genetic level.
All right, so to really understand the science, let's start where it matters most, with the patient. We'll begin with a pretty common clinical scenario.
Let's meet Liam. He's a happy, healthy 2-year-old boy, but he's been brought into the emergency department after just a simple tumble while playing. But look at his knee. It's incredibly swollen, it's warm, and it's clearly very painful. It's a reaction that's way out of proportion for a minor fall. And this kind of thing, it immediately raises a red flag. In fact, a lot of kids are diagnosed right around this age, just as they're getting more mobile and picking up all those normal, everyday bumps and scrapes.
Now for Liam's family, a diagnosis of hemophilia is a total shock. They have absolutely no history of any bleeding disorder. And here's what's so important to understand. This isn't unusual. While we often think of hemophilia as being passed down through generations, about a third of all cases are brand new. They're the result of the spontaneous mutation. This means the condition can literally appear for the very first time in a family with no warning at all.
Okay, so to figure out what's going wrong inside Liam's knee, we first have to appreciate the incredible process of normal blood clotting. It's not just about plugging a hole. It's more like a sophisticated, multi-phase construction project, and its whole purpose is to build a strong, durable seal.
You know, the modern way of looking at clotting involves 3 phases that all overlap. It starts with initiation, and you can think of this as a tiny little spark. When a blood vessel gets injured, it creates a very small amount of an enzyme called thrombin. Now, this initial spark isn't nearly enough to stop the bleeding, but it's essential for phase 2, which is amplification. Here, that small bit of thrombin primes the entire system, activating platelets and other key factors, getting everything ready for the main event, propagation. This is where the real clot-building machinery kicks into high gear.
Now, the ultimate goal of this entire cascade is to create a strong mesh made of a protein called fibrin. And here's the best way to think about it. If platelets are like the bricks that first rush in to plug the hole in the vessel wall, then fibrin is the super strong mortar that hardens around them, locking everything into place. Without that strong fibrin mortar, the platelet wall is weak, it's unstable, and it just gets washed away, allowing the bleeding to start right back up again.
Okay, so let's pinpoint exactly where this elegant process breaks down in hemophilia. The first 2 phases, initiation and amplification, they actually work pretty well. The problem, the breakdown, happens during that critical 3rd phase, propagation.
This right here is the single most important concept to grasp. Patients with hemophilia can make the building blocks for fibrin just fine. The problem isn't the material itself. The problem is a failure to generate enough thrombin. That's the master enzyme that converts the soluble fibrin building blocks into that strong, insoluble mesh. It's kind of like having a pile of good mortar mix, but not having enough water to actually activate it and make it hard.
So what does that actually look like? Well, in a healthy person, that propagation phase creates what we call a thrombin burst. It's a massive, explosive production of thrombin that ensures a really tough fibrin clot forms and forms fast. But in hemophilia, that burst is missing. Instead, what you get is a thrombin trickle. Just a slow, insufficient amount is produced, and the result is a flimsy, unstable clot that just can't hold up under pressure.
And what causes this failure? The defect lies in a specific molecular machine. It's called the 10-OSI complex. It's made of activated factor VIII and factor IX. And this complex is the powerhouse. It's the engine that drives that thrombin burst. I mean, it amplifies the production of the next factor in the chain by several thousand times. In hemophilia A, you're missing factor VIII. In hemophilia B, you're missing factor IX. But either way, the engine is broken, and the whole production line just grinds to a halt.
This molecular failure, this inability to form a stable clot, translates directly, and sometimes devastatingly, into the clinical signs we see in patients like Liam.
Because those weak clots just can't seal even minor damage, bleeding is prolonged, and it tends to happen in very characteristic places. The most common sites are the joints, a condition we call hemarthrosis, especially in the knees, elbows, and ankles. Bleeding into muscles is also very common and can be really dangerous, but the complication we fear the most is bleeding inside the skull, an intracranial hemorrhage. It's still the leading cause of death for people with hemophilia.
And the long-term consequences of those recurrent joint bleeds are profound. It turns out that blood is actually incredibly inflammatory and toxic to the delicate lining of a joint. So over time, repeated bleeds cause chronic inflammation, which then destroys cartilage and erodes the bone. This leads to a really debilitating condition called hemophilic arthropathy, causing chronic pain, deformity, and a severe loss of mobility. So you can see how it deeply affects the skeletal and muscular systems.
So, how do we confirm this diagnosis in the lab, and more importantly, how do we go about repairing this broken chain in the clotting cascade?
The diagnosis really hinges on a couple of key lab tests. The APTT test measures the integrity of what's called the intrinsic pathway. That's the part of the cascading involving factors that are already circulating within the blood, which is exactly where factors 8 and 9 do their job. So in hemophilia, the APTT will be significantly prolonged. In contrast, the PT test, which measures the extrinsic pathway, initiated by tissue injury, will be completely normal. This classic pattern is really the telltale sign of hemophilia.
What's truly exciting is how the therapeutic landscape has just been revolutionized. The classic approach is pretty straightforward. Factor replacement, you just infuse the protein that's missing. But now we have these brilliant non-factor therapies. For example, one drug cleverly mimics the function of factor VIII. Another class, called rebalancing agents, works by inhibiting the body's natural anti-clotting proteins, which essentially tips the scale back in favor of clot formation. And finally, we have gene therapy, which offers the potential for a functional cure by giving the patient's own liver cells the blueprint to produce the missing factor themselves.
So to really complete our understanding, we have to look at the genetic origins of this disorder and see its ripple effects throughout the rest of the body. The genes for both factor VIII and factor IX are located on the X chromosome. Now, because males only have one X chromosome, a single defective gene means they have the disease. Females, who have two X chromosomes, are usually carriers. But here's a critical point for advanced practice. Because of a random process called lyonization, some female carriers can actually have factor levels that are low enough to be symptomatic and experience significant bleeding problems themselves.
You see, hemophilia's impact echoes far beyond just the circulatory system. We've already talked about the devastating effects on the skeletal system and the risk to the nervous system. But the cardiovascular system presents a really fascinating paradox. Because of the physical inactivity that comes from having painful joints, patients often have higher rates of hypertension and obesity. And yet, their impaired ability to clot actually protects them, leading to lower rates of heart attack and stroke. It creates a really complex balancing act for managing their overall health.
All right, let's quickly recap this whole story, connecting that single molecular defect all the way back to the clinical picture.
So, it all starts with the need for a powerful thrombin burst to build a stable clot. In hemophilia, a defect in the tenase complex, that engine of the process, breaks the chain. This leads to just a trickle of thrombin, resulting in a weak, unstable fibrin clot. That faulty clot is the direct cause of prolonged bleeding, which in turn leads to joint damage and other systemic issues. And our modern therapies, they're all designed to fix that one broken step by replacing the part, mimicking it, or rebalancing the whole system.
You know, we're at a truly remarkable moment in the history of this disease. For the first time, we can realistically talk about a potential cure through gene therapy. But this opens up a whole new frontier of questions. How can we ensure these treatments are not only safe and effective for decades, but also accessible to the millions of patients around the world who still lack even the most basic care?
This video is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions. Stay pathocurious and see you next episode.